So guys, in terms of managing hyperkalemia, we said that you can have hyperkalemic emergency, or you can have non-hyperkalemic emergency. So we said, when do you say it's an emergency? Just to repeat it, someone who's symptomatic. So a patient is symptomatic, weakness of the legs, twitching, paralysis, things like that. Patient with ECG changes. A patient who's got a potassium concentration of greater than 6.5, whether symptomatic or not symptomatic. A patient who's got a potassium of more than 5.5, who either has got renal failure, who has got an ongoing catabolism, who has got ongoing absorption like GIT bleeding, where a lot of potassium is absorbed from the GI. So these are emergency patients, and we said that these patients, they need IV therapy. And we said that the IV therapy and we said that you can, while you are still preparing your IV therapy, you can give this patient beta 2 agonist. But remember, the beta 2 agonist will not stabilize the heart, so your ECG changes are going to continue for some time. That's why we need IV. So you are just buying time while you are preparing. So in that combination, you need calcium gluconate, we need insulin, we need glucose, and we explained that insulin. So we explained that calcium can, what we need is calcium. You can either have calcium gluconate or calcium chloride. So those are the two preparations that you can use, but the most commonly used one is calcium gluconate. And we said that this is just for stabilizing the membrane, the cardiomyocytes, so that you can get rid of your ECG changes. Then this is for shifting. Insulin is the main one for shifting. Glucose is there to prevent hypoglycemia, because this, the ATP, the sodium potassium ATPase that is going to be activated by this insulin requires a lot of energy. So a lot of ATP will be used. So if the patient has got low glucose, they will have hypoglycemia. So you give glucose, and then after doing that, you still give them an infusion and check blood sugar hourly for about 6 hours to make sure they don't develop hypoglycemia. That's one. Number two, we said that after doing this is just for shifting. Now you need to take out potassium out of the body. You can use diuretics. You can use I mentioned Kayexlate, which is a gastrointestinal cation exchanger. You can also use you can dialyze the patient, hemodialysis. So those are the options for a patient who's got this. Now, what do you do for a patient who's got so here you can have two kinds of patients. You can have patients here that you need to reduce potassium within 6 to 12 hours. They're not an emergency now, but they can become an emergency. These ones, you can do it slowly, not a problem. So obviously, it's going to be patients who do not have any of the things that we mentioned, the criteria for emergency. So these are the patients that have got oliguria, patients that have got end-stage renal disease. So these patients, you want to decrease it within 6 to 12 hours. The difference is that you don't have to give IV here. No IV is needed for these patients. So the options that you have is here is your diet. your diuretics. You can diuretics. And then here you can give you can do diuretics here. You can give beta blockers. You can give depending, but the end goal that you want is to dialyze these patients. They will benefit from dialysis because you don't want them to be there. So the main thing here is to dialyze. Anything that you'll be doing, yes, your carboxylate, all of that, you can give your carboxylate. It's just buying time. But what you want, you will manage them with these, but your end goal is you want this. But if you can't, then you will keep giving them the other options, carboxylate and diuretics. Yes, guys, this brings me to yes, we can all follow your protocols where you're working, but this is just a broad overview of stuff. And yeah, while we are still here, I want us to talk about, okay, let's quickly talk about ECG changes. The ECG changes. So remember, potassium plays a very big role in repolarization, and the T wave is ventricular repolarization. So you start developing tall peaked T waves that go like that. That's the first thing. As this is pulled up, you start developing a flattening of the P, flattening, so peaked or tall peaked T waves. One. Number two, P wave problems include it can be flattening, or they can become stretched out first. Flattening, they can become wide, and then they flattening of P waves, and also a prolonged PR, which now by definition is a heart block, and then you get QRS that widens. And there's a lot of debate whether there's a correlation between ECG changes and the amount of potassium in the body. Different articles are saying different things. So I wouldn't like to say when the potassium is this, you're gonna get this. But later on, you get things like a sine wave, and then you get a systole, whereby this has just flattened out now. A systole. So these are things that require practice to see them more and more and more and more. I haven't diagnosed a lot of ECG pathologies myself. I've diagnosed maybe about not more than five. Yeah, but when you pick them up, they boost your confidence. It becomes very good. Yeah, so basically these are things that you expect. So now that we're done with this, I want us to talk about drugs. Let's talk about drugs that cause hyperkalemia. Very important. Drugs that cause increased potassium. Oh, guys, drugs that cause, any drug that acts or inhibits the rest system will cause hyperkalemia, because basically it's blocking aldosterone there. So like things like direct renin inhibitors, your ACE are well documented for this. ACE inhibitors, your aldactone antagonist, potassium sparing drugs, yeah, basically. So So these drugs will do that. But and while we are still here, there was this teaching that when you give a patient Lasix, you have to give them potassium supplements. It's no longer the case, guys. If you give a patient Lasix, but in their treatment you have AC inhibitor, or you've got a potassium sparing drug, you don't have to supplement these patients on Lasix, no matter how much the Lasix they are taking, because this on its own does cause hyperkalemia, and obviously, as we know this. And I've seen a patient who was referred from the clinic because they had hyperkalemia and they were on enalapril. But the blood sample was 2 weeks old when the patient came to me. So when I repeated, it had already corrected itself. So what I'm saying is, when you give a patient Lasix, which is a potassium wasting drug, if your patient is on this or this, you don't have to supplement them. And I've been changing a lot of patients who at the clinic who are on supplements, or potassium supplements, because they are on Lasix. So the new guideline says you don't have to give that. That's the point that I wanted to make. Other drugs that cause hyperkalemia are your beta blockers, especially non-selective beta blockers. Remember, we said that ATPase pump, one of the things that causes it to pump potassium from the outside of the cell to the inside is beta 2 receptor stimulation. Now, if you give a patient beta block and then you block this, then you are basically saying that ATPase pump must not work, must just sit there, and then you allow accumulation of potassium. So beta blockers, especially non-selective, this thing is not, it's like NSAIDs. NSAIDs also, they do cause an increase. Digitalis, like digoxin, they do cause, and also obviously suxmetonium does cause. So, I want you guys, if you get a chance, please go and read about NSAIDs and the kidneys. These drugs are horrible drugs. Especially, the effects are not seen when the patient is not old, is a young patient, doesn't have a lot of comorbidities. But when you are old and taking a lot of drugs and having a lot of comorbidities like renal problems, cardiac problems, liver problems, they become very important. These drugs are nephrotoxic. One of the things that these drugs they do, remember, when you have renal problems, you depend on your prostaglandins secretion to maintain renal perfusion. So I'm saying, when you have got a lot of comorbidities and you've got renal problems already, you get to a point whereby you depend on prostaglandins to maintain renal perfusion. But now these drugs, they counter the production, they inhibit the production of prostaglandin. So they worsen the decreased renal perfusion rate that has been happening because of maybe atherosclerosis, or because of like renal atherosclerosis, or because of cardiogenic shock. The patient has got reduced cardiac output, chronic reduced cardiac output, and things like that. And also, you've got a REST system that is remember, in cardiac failure, the REST system is activated chronically, and that REST system is the one that worsens heart failure. Now you've got that on top of this. So these NSAIDs drugs, the prostaglandin that they inhibit plays a role in vasodilation to allow renal perfusion and improve renal perfusion. But if now you stop it, you are worsening the renal perfusion that is already at risk. One of the things that have been found with these drugs is that they cause a lot of water retention. They cause a lot of water retention, and patients, they, even though they don't really become swollen clinically, but it's been proven that it causes a lot of renal retention. That's why patients got a renal problem and chronic hypertension, NSAIDs should be avoided, and cardiac NSAIDs are bad, guys. Especially if you are old with a lot of other comorbidities, NSAIDs are not good drugs. There are other reasons as well for not using NSAIDs. Yeah, as we know, NSAIDs, they cause also hyperkalemia. And what else? So the effects of these, they become very crucial on a sick patient. On a very, very, very sick patient, they become very crucial. I want to see if I'm not forgetting something here. So yeah, guys. So we said AC inhibitors, obviously also the ARBs, they also do cause hyperkalemia. So we'll use a lot of these drugs, AC inhibitors, ARBs, beta blockers, NSAIDs, and all these drugs. So, which means when you have a patient with hyperkalemia, we have to withhold these drugs and look for an alternative, especially if we are treating those hyperkalemic emergency patients. We need to remove the offending drugs. So guys, I'm not sure if I'm forgetting anything about hyperkalemia. If I remember, I will make a small video for whatever that I've forgotten, or just comment on it. But I think this is hyperkalemia. Okay guys, thank you so much. I hope you enjoyed that